I'm going to talk to you now about hepatitis C and how we reach elimination from a clinician's perspective. And we've talked quite a bit about the WHO viral hepatitis elimination goals. Just to be clear, these are really actually more goals about control than true elimination. Nevertheless, they're incredibly ambitious. So that's a reduction, and in hepatitis C, it's a reduction in incidence of 80% and a reduction in liver disease-related mortality of 65%, testing to go to 90%. Treatment to go to 80% by 2030. So really very ambitious goals set by the WHO. Now, the current reality is this is data from the Polaris Observatory, and it's continually updated. It's quite interesting to see countries fall off and sort of go back on. But you can see there in green, there are only 9 countries that are currently on track to meet those targets. Australia, where I'm from, is luckily one of those countries. There are only 2 low middle income countries, Mongolia and Georgia, included in that list. And unfortunately, as you can see, in the Western Pacific, there are no countries yet there. Now, even in Australia, which is on track to meet those targets, we had very initial encouraging DAA uptake. You can see there at the right-hand side of the graph in the orange, after the government-funded Universal Access Programme opened in 2016, a massive uptake in the number of people treated for hepatitis C. And by the end of 2017, that was just under 2 years worth of the programme, around 60,000 patients had been treated, about 26% of our chronic hepatitis C population, which was a huge achievement. However, even in the setting of universal access, our treatment numbers have declined. And obviously, there was a large amount of warehousing of patients that happened, and huge treatment numbers in the first few months, and that has now fallen back, and we continue to see a small decline in treatment numbers. So universal treatment access is certainly not the answer to elimination on its own, and there are major public health programmatic government challenges that we'll have a chance to discuss later in terms of achieving elimination. So I'm going to sort of bring it back down because I'm not going to address those large questions, but really talk about how does the clinician help achieve elimination. And I think this is where the concept of micro-elimination has started to be talked about. And what this means is, rather than trying to answer huge questions about elimination, which some people have to do in the world, but for us as clinicians, how do we achieve elimination within the population that we're working? And we might work in different populations with different groups. We might work across different groups. These might include drug and alcohol clinics. It might be an inner city primary care practice. It might be in a dialysis unit. It might be a community relevant, for example, to many people here, for example, HIV-positive gay bisexual men who have a high risk of HCV transmission. So it's about achieving elimination within your community as a clinician. And I think there are a number of steps that I just want to talk through about how you go about doing that. So the first thing is to find your patient. Now, that sounds very easy, but if you look at any treatment and linkage to care cascade for hepatitis C, you will see there's pretty much the same picture. And this is the Georgia experience. And the biggest step, the biggest loss, if you like, in that cascade is between the people who are estimated to be infected and the people who are actually diagnosed. That is where the most of the work actually needs to be done. And if you look at diagnosis rates by country, we're very lucky in Australia. Another reason why we should be doing really well in terms of elimination, we have high diagnosis rates of around 80% and above in our population, but most other countries falling way behind that. And I think we heard from Poland yesterday that in the Western Pacific, it's about 23% estimated as diagnosed as hepatitis C positive. So this is the first challenge, to actually find the patients. And that requires different strategies, depending again on the community or the population that you're working with. If you have a population where the prevalence of hepatitis C is high, for example, in a drug and alcohol clinic, in a prison setting, then universal screening of everybody is clearly probably appropriate. At a population level, depending on how the epidemic looks within the population, cohort screening might be appropriate. And this is the strategy that the US have taken with their baby boomer targeted screening to a birth cohort. And certainly at a population level, that might be relevant in some settings. And then there may be other practices where there's a low prevalence of hepatitis C, where it may be much more a risk-based or a targeted screening, a sort of case-finding approach. But really just to emphasize that if you're going to follow this approach to finding your patient, then the risk-based has to be asked about. It's not assumed risk-based, and that's a problem that we've found a lot. So you need to be asking about risk all your patients and then screening. And certainly finding patients needs a real innovative look at how to do that. Rather than waiting for the patients to come to you and turn up in your clinic, you have to know your population, then you have to go out and find them. And in Australia, we see more and more many innovative models of care to go and find patients, often taking vans out to communities on the street, to setting up community health clinics, to working with peer groups to engage people into services. So again, it needs to be targeted to your different population. The second step, once you've found your patient, once you've decided how you're going to find patients in your practice, is to diagnose them. And then again, that sounds pretty simple, but in fact, that's one of the major problems where we see a lot of fall-off of patients in their linkage to care. So traditionally, the route to a hepatitis C diagnosis is a long one. You get your antibody, you have your blood taken, you wait for that to come back, you come back and get the test, and if it's positive, then you have your blood taken again to get an RNA test, and then you come back and get that. And clearly in that schedule, there are plenty of options for patients to fall off. So one of the things that has really been very important is the advances in diagnostics and point-of-care testing for hepatitis C, and that includes rapid diagnostic tests for antibody testing, so oral testing, antibody, dried blood spot testing, the Gene Expert machine. Many of you will be probably starting to become already familiar with fingerstick testing at sites. And the whole idea of this is to move that period of diagnosis through to a single visit where you just get everything done in one session. So you get a rapid test, then a reflex RNA maybe that takes 2 hours to come back, and then you get put through to consider treatment. So I think it's important to consider when you look at those different diagnostic strategies, what is important for your population. And again, it depends on what the population looks like that you work in. It may be important to remove the need for phlebotomy if you work in a population which has very difficult venous access or doesn't like having blood taken. So dry blood spots ideal, capillary tests ideal in that setting. It may be important to have an in-field test where you can go out to community health clinics where you don't need to have be near a lab. It may be important to do rapid mass antibody screening that you can do very quickly on large numbers of patients. It may be important to reduce the time from testing to linkage, particularly in patients that you think might not be likely to engage or might be lost to follow-up. Or it may be immediate treatment at first point of access. And depending what the needs are in your different setting, you can devise which combination of testing strategies you may want to put in to help bring patients into care. The only other thing I want to say about diagnosis, the only other question I think you're going to have to make in terms of diagnosis is the patient cirrhotic or not as we move forward? And clearly FibroScan's a great tool for that if you have it, but just to recognise that there are many other, or several other ways of determining whether a patient is cirrhotic or not, and this is important because it determines the duration of therapy sometimes, but also it determines whether you need to follow the patient up for liver cancer surveillance. In Australia, many of the primary care practices who don't have access to a FibroScan will simply use an APRI score based on the AST and platelet count. And an APRI, if you do it and it's less than 1, which is the situation in most patients in primary care, that has a very high negative predictive value for excluding cirrhosis. So you can be confident your patient doesn't have cirrhosis and you can go on and start treatment. If you don't do that, at the very least, what you can do is look at the platelet count. And if the platelet count is 90 or less with no other reason, then that would be certainly to me indicative of portal hypertension. And that's a very simple, quick thing you can look at to know which patient may be in trouble, which patients you need to think about, are they cirrhotic, and do you need to actually send those patients through for further assessment. linking your patient. So I think what I'm trying to say here is that in terms of prescribers, it's very important if we're going to achieve elimination at any kind of level that we move treatment out of the tertiary hospital setting, because it simply will not be able to cope with the volume of patients you need to treat to eliminate hepatitis C. And this is data from Australia. And in the purple there, you can see the percentage of scripts that were written by month by primary care physicians. Now, we have a situation in Australia where primary care physicians can write prescriptions and others can for hepatitis C therapy. And you can see a really encouraging uptake of prescription by our general practitioner base. And this is critical, so we have to move it out from the care of the specialists. And in fact, there's data coming through very clear to say we don't need specialists in most cases, apart from those very difficult to treat patients, the very advanced cirrhotics. This is data from the REACH-C cohort. It's a real-world efficacy cohort in Australia. We're following around now 4,000 patients. Really just to show that treatment outcomes across the board are incredibly good in a real-world setting, whether you've got injecting, whether you're on OST, whether you're HIV positive, whether you've had prior treatment. But importantly, relative to this, is that this cohort takes data from a number of different settings: GPs, sexual health services, community health clinics, drug and alcohol services, prisons as well. And you can see that the SVR rates across all of those services are almost identical. So there is no suggestion that treating outside of the specialist setting impacts on the ability to achieve an SVR. So how to broaden access to hepatitis C services? Well, certainly you need to take services to the places where the patients are, and we've talked this morning about that in the setting of HIV, but I think we need to also broaden our attitudes towards hepatitis C and take it out into the community where your patients are, know where they are, and go and take treatment to them. Outreach being done from tertiary care hospitals, educating drug and alcohol specialists, general practitioners, and using patient and peer navigators to help facilitate linkage. These are all important things that can be done. After that comes treatment, and in fact I'm going to talk relatively little about treatment because we'll talk about access to treatment later, but I'm sure that mostly everybody in this room knows that hepatitis C treatment is now incredibly easy, and I think one of the things that we've learnt in Australia is that just how simple it gets. So we started off with various guidelines and things you had to do before you commence treatment, and we've really got rid of pretty much all of that now. This is the Georgian elimination cascade again, at the other end of the cascade, and there you can see the drop-off in terms of treating and then cure is incredibly tiny. This is not where the problem exists in terms of an elimination agenda. We know that the hepatitis C therapies have evolved so well and so rapidly to become incredibly efficacious, greater than 95-96% success rates across the board in pretty much all patients, and very tolerable. Now, I know that many of you may have various amounts of access to these drugs, but clearly this is going to change. And the advent of sofosbuvir, velpatasvir, which is pangenotypic, and most recently for us, we're just getting the AbbVie pangenotypic regimen, which can now be given 8 weeks for non-cirrhotic patients. These are very, very important steps in giving us the tools that we need to achieve elimination, but they are by far from the answer across the board. In terms of the outcomes, for example, in the HIV-positive population, there is really no suggestion that HIV patients have any worse outcomes than mono-infected, whatever regimen you have, whatever you use. And in fact, the only things that do tend to consistently predict treatment failure in a very small number of people, this is only 2-3% of people with any of these regimens generally, are things like having cirrhosis, being genotype 3, treatment experienced, having 2 or more of these factors. But it's a very small number of patients. In terms of elimination, the other thing is important is not just to treat the patient, but to retreat the patient, because reinfections will occur. And if you're talking about elimination, what need to be doing is targeting populations where transmission is an issue. And if you're targeting those populations, you will see reinfections within those populations. And what you need to do is not be disheartened, and need to talk to your policymakers, whoever is funding your programs, and say this is what we expect, and you know, this is a good thing. It means we're getting to the population we need to get to bring down incidence. And this really just shows in a schematic way. In fact, as you scale up, you will actually see an increasing number of reinfections until you pass through that hump, if you like, and get enough patients treated to have a protective effect. And I have to say, in Australia, what we're seeing at the moment is incredibly few reinfections, certainly within certain populations, such as the co-infected population, because we've reached such high treatment numbers. Clearly, treatment as prevention is not enough to achieve elimination. And I just really wanted to sort of add the final thing is that it's important to protect our patients from new infection and reinfection, and not to forget that the WHO goals also focus very much on prevention and harm reduction, and there are clear targets, for example, around needle and syringe availability. You can see the baseline we're at the moment is around 20 per person per year in people who inject drugs, and that really needs to go to 300 per person per year by 2030. And harm reduction prevention is a really important component of the whole elimination package that we shouldn't forget. We've talked, I think, across the conference there's been some talks about trains and things, and I guess I want to finish by saying I know that many of you here are not in the situation that we are in Australia, where we do have universal access and ability to treat, and every prescribers can treat, but things will happen really quickly, and it's important, I think, to plan your program now, to understand your population now, to think about how you're going to screen, how you're going to engage in care, because these are the real difficult things to do. It's not going to be the treatment, because when the treatment comes, and it will, that is not going to be the sole answer to elimination. I am just going to finish by showing you this, because I think actually in our co-infected individuals, they might be one of the first population where we may actually be able to show that elimination can occur. And this might be because they're very much linked into care. They're being treated by prescribers who are used to prescribing antivirals. So the GPs in Australia have taken up prescription of DAAs very rapidly. And this is data from a cohort study called CEASE that we run, looking at what has happened to our co-infected population during the period of rollout from 2014, before we had DAAs, through to 2017. And you can see there that the proportion of people who have active virus in that cohort of co-infected individuals has fallen from 80% down to 18%, and we're expecting it to be less than 10% in the coming year. And if we can achieve levels like this, then certainly in this group we are likely to achieve micro-elimination. So I'm going to finish there, just to acknowledge that any elimination program comes with a lot of help, both from people and the communities, and it's really important to work all together to achieve this. Thank you.